Welcome to our first and only iSPARC Research Seminar this year. My apologies for being tardy. I somehow didn't get the link in my calendar. Thank you for coming, everybody. And I could not be more pleased to be introducing our guest speaker today, Dr. Enola Proctor. You all have her bio. You would have received her bio. So I'm just going to go over a few highlights. First of all, she's the Shanti K. Kinduga, I hope I pronounced that right, Distinguished Professor Emerita at the Brown School, Washington University in St. Louis. I believe she is sort of half retired and yet still traveling all over the country, spreading her expertise on implementation science. And so we are so grateful that she was willing to spend the day with us. Many of us get to meet with her today, in addition to hearing this presentation. She's a PI and director of the Implementation Research Institute, IRI, which is a 2-year national training program in implementation science funded by NIMH. I have several colleagues who have attended this training and have raved about it. We've heard great things. She's also served on the NIMH National Advisory Council and on the Institute of Medicine's Committee on Evidence-Based Standards for Psychosocial Interventions for Mental Disorders. She's a founding member of American Academy of Social Work and Social Welfare and a fellow and board member for the Society for Social Work and Research. Dr. Proctor's work advances the intellectual capital for the rapidly growing field of dissemination and implementation science. This has led to distinguished, clearly defined taxonomies in implementation science and some methodological clarity in this field. She's been funded by NIH quite a bit in implementation science. In fact, she has written articles about how to write grants to get grants that involve implementation science. And I'll just say, as someone who I'm considered a novice in implementation science, who's been trying to learn as much as possible over the last few years, that Dr. Proctor is probably someone I've cited more than anybody in this field, has developed many of the implementation outcomes and defined them. So we're just very grateful to have you. And without further ado, I will turn it over.
Thank you, Gina. Can everybody hear me and see me okay? Is everything working well? Great. Thank you. And as I've said to a couple people, I was really looking forward to being with you in person. We've all had to change plans and be flexible, and we've had to continue doing that much longer than we envisioned when we were hoping that I would be with you last spring. But I've really enjoyed the meetings that I had yesterday and this morning, and I'm looking forward to having an opportunity to chat with some others of you later this afternoon. So I am half-time retired and enjoying that and having more time to think about issues in implementation science that I care about, and also kind of opening the door to the non-work part of my life, which, as we know, that's hard to do when we love our work and when there seems to be so much of it. So, so my work has always been focused on the pursuit to improve mental health care, as I know that the work of several of your centers and several of you investigators have. And I think especially as we think about a presidential election and the difference that federal leadership can make, I always hearken back to President Jimmy Carter's initiative to ask the question, how good is our mental health care? And many of you may have heard, as I've had the privilege of hearing his wife, Rosalind, say that she's the one who began bugging Jimmy about mental health, because while she was helping him campaign even for governor of Georgia, many people, while they were waiting in line to shake his hand and she chatted with them, said, please asked the governor, what can I do to help get mental health services more available to my loved ones? So she tells the story that in one receiving line, or one greeting line, she got in line and shook his hand and said, Jimmy, what are you going to do to help improve the care that people with mental illness are getting? And so that led to the first presidential commission. So, that's been many decades, maybe 4 or 5 decades ago. And in the meantime, we have tried to address that challenge through a number of ways. We have worked to improve access by extending hours, by trying to get more information out about sources of service. We have tried to improve system coordination, linkages, connections, referral routes. We have worked to co-locate mental health services in many settings that might not be defined as primary mental health service settings, such as schools, the criminal justice sectors, social services. I've done a lot of work in that arena, aging services, emergency departments. We've worked to try to take, if we can't get people to the system, we've worked to try to, if you will, take services to people in the settings where they are already receiving something for help.
Excuse me, Dr.
But access to care and extending the reach of care is not enough if we aren't connecting them with high quality care. So a more recent and continuing challenge is, how do we make sure that whether in specialty mental health settings or other settings, people with need are receiving evidence-based interventions.
Excuse me, Dr.
This is really important because we know that primary care is often the first place that people seek help, and it's not just for mild mental disorders. We know that often the first presentation of a psychosis happens in primary care or other general medical settings. And the research of our teams has shown that 20 to 50% of people entering various social service settings evidence need for mental health care. We have worked to tighten up this integration, extending care, and yet we have huge gaps in access. A recent study showed that of people needing mental health care, over half are not getting treatment, sometimes because they can't afford it. We still have a lot of stigma. People think they can handle mental health issues on their own. They don't know where to go to treatment in spite of our efforts to co-locate, or they don't have time in spite of our efforts to increase accessibility. Y'all know who I am, what I do, and you know that, like you, we're working on advancing the access and quality of mental health services. We're all having to do a lot of, I don't think the word pivot is adequate. We're all having to do major lane shifting. So I'm happy to have shifted lanes to let you get on board. So yeah, most people are getting no treatment. We know the barriers, and we're all on board with trying to improve quality. And I know that, from looking at your websites and the discussions that I've had, I know that, the mission of your iSPARC Center clearly aligns with the priorities of improving the quality of mental health services in our systems, and ensuring that those services actually help promote people's recovery and improve the quality of life. So if we're trying to improve the delivery of evidence-based interventions, we have a long way to go. Several studies show that even among states who are working in structured ways to roll out evidence-based treatments, the saturation is very, very low. Even among states that say they are delivering mental health care, many people are not getting evidence-based care. So we have been challenged by what used to be the national, it is now the National Academies Press from Institute of Medicine reports, starting with physical medicine to err is human, and then describing a gap between the care that could be and the care that we actually are delivering. Looking at the slides, the larger box and then the light tan box reflect reports from the National Academies Press that focus on behavioral health conditions and lay out a number of challenges around this theme of how do we improve the quality of care? What is it going to take? So what we're going to be thinking about today is how we can improve evidence-based care in real-world settings. And I know that's exactly what your studies are trying to address. In May, the NIMH released their final version of the current strategic plan. And I want to call your attention to Strategic Objective 4, which really looks at the public health impact of NIMH supported work. And you will find a home there in that strategic plan for many of the priorities associated with dissemination and implementation research. So one of the objectives that is highlighted is to expedite adoption and sustained implementation and continuous improvement of evidence-based mental health services. And some of the avenues toward that are through partnerships, through figuring out how we can scale up evidence-based practices for a whole range of settings, including many of those that I know you do your work in, and then developing decision support tools and leveraging technology that can help us improve both the reach and the quality of mental health care. Many of you, I hope, are familiar with a more cross-cutting priority that spans the entire NIH, while the strategic plan that I showed on the previous slide is specific to NIMH. This cross-cutting program announcement calls for dissemination and implementation research proposals by 18 different centers and institutes. And this was updated most recently in 2019. And I view this program announcement as actually kind of a primer for many definitions, for identifying priorities. And I think it's really important that we align our research agendas with the public health significance of our work, and some tips or hints of, for ideas and priorities can be found both in the strategic plan and also in this program announcement. This program announcement clarifies that the purpose of dissemination and implementation research in health is to figure out what strategies can help us achieve the implementation outcomes of adoption, adaptation, integration, scale up, and sustainability. And the thing that we are to be working toward implementing are evidence-based interventions, policies, tools, guidelines. And those of you who are doing intervention development work may find that a good stepping stone toward more concentrated implementation focus in your work is those particular evidence-based interventions that you've been developing through your effectiveness research. In addition to trying to figure out strategies that work, The program announcement challenges us to think about stopping or reducing interventions that really aren't doing much good. Some interventions are actually, even though they're widely delivered, they are ineffective, or they have a lot of champions and followers and adherents, but the evidence has not really proven how they work or for whom they work. Some interventions are low value for the investment that they require. Some are even harmful. And I think we know in behavioral health that our interventions do have the capacity to sometimes be harmful. And I think if we, as we all do, since we're researchers, if we believe in the continual accruance of evidence, we need to hope that next year or the next decade's interventions will be even better than the ones that we're delivering right now. So I see de-implementation as part and parcel to implementation in our effort to improving care. Now, that's not to say that I haven't valued and haven't done work and still value sustainability, but I think there's a real tension between being constantly sticking with something that is familiar and tried and true and we know how to do, versus fostering the kinds of learning environments where we can always be open to new discovery and nimble or facile in our organizations and in our own provider skill sets to adopt something that might be better. So it's exciting to see that this program announcement puts forward some of the cutting edge issues to help us be thinking about where we're going down the road. Of course, the program announcement also distinguishes dissemination research from implementation research. If we were across the border in Canada, we would use one phrase to characterize both these fields, and that would be knowledge translation. But the NIH has chosen to distinguish between dissemination research and implementation research, with dissemination research really being focused more, the what there is really information and materials and scientific evidence, where implementation is focused on strategies and the how to do. And I hope that dissemination research will receive even more attention. I think it's been underemphasized, although my sweet spot, the work I like to do is implementation research, but I'd like to see comparable advances in dissemination research. And I think one thing COVID-19 has done is put many scientific challenges and conundrums out there in the public eye. I know many of you, like I, may be reading an article about, distinguish. Now the public knows the difference between phase 1, phase 2, and phase 3 trials for vaccine. They know issues of safety and efficacy. And so this terrible pandemic has highlighted many research issues in our public policy and public discourse, and certainly the extent to which evidence is received, is believed, is viewed to have credence remains a serious challenge in our society. And that's really where dissemination research will, I think, have a lot to contribute. So, I have always been excited about a very simple definition of implementation science that at least 15 years ago, maybe 20, I heard Carolyn Clancy, who was then the director of ARC, say, she said, implementation is just making the right thing to do, the easy thing to do. And unfortunately, it's rarely easy. I think no one wants to be delivering substandard care, but improving care is hard. And therefore, in implementation science, we face a number of challenges And some of those challenges are what I want to lay out. I think most of us are familiar with this now decades-year-old distinction with phases of research in sort of a pipeline or a progression notion. We have some newer ideas in implementation science that challenge the the necessity of a sequential progression of research designs. And I'll talk about that a little bit. But I love that, these stages help us distinguish what to target, which is pre-intervention research, what to deliver, and how to deliver it. And certainly we can see these three questions playing out in public discourse around COVID. We're not really sure what these vaccines should be targeting. Should they be boosting immunity? Should they be killing the virus? So there's a lot of basic science that is trying to figure out what to target. Similarly, we've seen variations in our public discourse about what to target with prevention. Should we target distance? Should we keep cleaning the surfaces of our groceries and packages and mail? Should we wear masks? Should we stay 6 feet apart? Should we stay 12 feet apart? Should we be indoors? How effective are ventilation? So we're still asking what to target. I think we've failed pretty miserably on the what to deliver and how to deliver it. We have a long way to go in getting public acceptance of something even so visible and so visibly harmful. Change is hard and a lot gets in the way. And any of us who, my path toward implementation research has been through health services research. So I've studied practice variation, variation in what interventions are delivered where. I know service systems, and I know that many of these challenges get in the way of change. I think our challenge in implementation science is converting those into facilitators for change. So this slide, many of you may have seen. I stole it with his permission, David Chambers, who was my project officer for many, many years when he was at NIMH and now a colleague at NCI. And he helped show some of the connections between types of research that can have synergy. This shows that dissemination and research are related yet distinct, and that there are some allied or sister fields that dissemination research can benefit from, and similarly implementation research from quality improvement science. And interestingly, he couches all of this activity within the broader the broader circle of health services research. So I want to share a version of a model that helped me sort out over a decade ago what implementation research looks like. I shared with somebody this morning, most of my papers really reflect what I didn't know. I write papers to teach myself. And I was actually working on the 3-time submission for the Implementation Research Institute that Gina referenced. Reviewers kept telling us this field was still developing and we couldn't train for a developing field. And I thought, what field is not still developing? But anyway, I had a very hard head. I kept persisting. But I needed to figure out what content I would need to include in a training program in implementation research. And I knew that a lot of the folks who would be coming to us for training would be coming from effectiveness research backgrounds. They were testing evidence-based interventions, and they were assessing those through measurement of patient outcomes. But that had been our usual model of research for NIMH and treatment development, also for service system research. But I thought, there's a second how, or there's a second moving part of an intervention. There's the evidence-based intervention, and then the intervention to get those evidence-based interventions into place, which we called implementation strategies. And it takes both of those to achieve implementation. I also was challenged to figure out how would we know if implementation were successful, and thought there are some risks, which I'll identify shortly, in relying only on patient outcomes. So we posited these more proximal implementation outcomes to see, are the evidence-based interventions, are they feasible for the setting of care? Can they be delivered with fidelity? Do they penetrate and reach a lot of people in the system of care, et cetera? And again, all of that is within the context of service delivery. So those became my foci for the core of implementation science. And I'll elaborate a little bit about each of those as I highlight some of the principles for this science. So I always begin thinking about implementation from measuring the quality gap or figuring out what services are actually being delivered. I was asked in a session yesterday, what's my approach to stakeholder engagement? Well, it's usually hanging with the system, knowing the providers, knowing the administrators. What pressures are there on them? What are they trying to achieve? What are their boards, their funding agencies, their stakeholders, the policies saying we need to do better at? I don't think implementation researchers can ever airdrop in and say, hey, I'd like to study the implementation of this, and I'd like to do it in your backyard. So knowing, the service system, what they're wrestling with, what services they want to improve, that's really, really important. And this requires collecting data. And many settings, especially those who still rely on paper and pencil or paper charts, and that do not use procedure codes, it's very challenging to figure out sometimes what is being delivered. So then we need to know, how good is the care? This is the question that Jimmy Carter challenged the NIMH with in the mid-70s, and that's really what spawned the whole service system portfolio at NIMH. How many people are getting good care? And in that first equation, we would look at the number of service recipients as the denominator, and then calculating the percent of those who are getting evidence-based care. If we want to be more ambitious and approach this from a population health or a public health perspective, we'll go beyond the number of people in the service system, and we'll begin asking how many people need this service and what proportion of them are receiving evidence-based care. So this is an important starting place for implementation research, because it tells us whether we have a big gap or we're getting close, and that can be really, really important. So there are some data sources that can help us. I'm a frequent reader of the iSPARC quality reports. They issue reports every year, and the reports don't include the same indicators every year. They try to include the same indicators every other year, but I pulled these from the most recently, or the couple of weeks ago's website. And are we seeing improvements? And we are seeing no change in the quality of care with adults with major depressive disorder who are getting treatment in the last 12 months, and similarly for children. Unfortunately, we're seeing worse indicators in suicide deaths. And so figuring out what percent of people are receiving, who should be receiving screening for suicidality or getting that screening, is an important first step in mapping the quality gap there. We do see some changes over time, but look at this incredible variation in the receipt of depression care for children with major depressive disorder. I mean, those are pretty marked swings, but you know, even at the peak, which was in 2014 and again in 2016, that's only 41% of kids. So we've got a long way to go there. And then suicide deaths for people 12 and up, we see, unfortunately, a steady incline. So there are data sources. You can collect your own data if you have the setting and agency indicators that let you calculate this. But knowing, you know, what is the quality gap is a really important. Oh yeah, I had this slide that is even worse, showing the receipt of depression care for adults sharply decreasing, which is surprising to me because I think we thought the Affordable Care Act and requiring behavioral health screenings in primary care settings was going to improve that. But of course, this is not just screening, this is getting care. So once we know the quality gap, then we need to know, you know, what intervention can improve care or reduce the quality gap. We need a repertoire of evidence-based interventions that could be implemented. And I think most of us are familiar with the multitude of sites that list evidence-based interventions depending on a particular disorder. These are updated typically at intervals that vary across these different sites. There are, of course, a multitude of practice guidelines from the American Psychological Association. And I particularly was grieved when a couple of years ago, SAMHSA took away its registry of evidence-based interventions. Now what we have is an evidence-based practice resource center that is just a connector to other websites. So, you know, we can conduct searches of these various websites to figure out, you know, what are the evidence-based interventions. And again, I hope we will see an increase in numbers and an increase in the rigor of evidence supporting the criteria that lead these things to be listed as evidence-based. However, you know, it's all about context. I have a T-shirt. I don't know how old it is, from the very first TITRE conference, that before it was lodged within NCI, and it says it's all about context. And indeed, context makes life interesting. It also makes implementation research inherently more challenging than clinical trials, where we can rule out all of that noise. But in implementation science, we say, oh, let's do it in the real world and bring in this variance. So we're faced then with the challenge of measuring, assessing context, and knowing what's going on with the setting and who are the stakeholders. Every setting has stakeholders, and usually researchers who want to do their work in these settings are not the most important stakeholder. Instead, the stakeholders are service users, families, providers, funders, administrators. And so all these people are going to have a say in the services that are delivered. And if we are working with a service system to change, we really need to know who's on board and who might be actively resistant to that change. So stakeholder engagement, knowing how people will react to change, and figuring out what motivates them and the best ways to reach them is a critical and step in developing an implementation project. In addition to, you know, demand, sometimes there's somebody pushing out, but what is the pull? Who wants this? And is there infrastructure to support the change that people are either pushing out or pulling for? Implementation science, of course, is nothing without a model. We like our models because they help us know the moving parts, what needs to be changed, the relationships between sets of variables. Many models can tell us when to do what. There are a number of phase models that can help us distinguish between getting ready, planning the implementation, doing the implementation, follow-up and sustainment. And models also help build our science, because if we can test the same model in a variety of settings and different applications, then we are enhancing generalizability. And for implementers on the ground, I try to help them identify a model that they feel applies to their setting, because it really reduces the feeling of haphazardness. And change is risky. Change carries a lot of cost, time and energy. And I think we should not go into that lightly. And certainly, I've always felt people deserve more of a plan than what's in my head. So I want to help connect them with a plan that other people have vetted and hopefully tested. There are many, many frameworks, and this is another example of a paper written by my colleagues that was an attempt to answer a question. The first year of the Implementation Research Institute, we decided to have a session on, like what framework and models should guide things. And during that session, we said, I wonder what frameworks and models investigators are reflecting in their NIH applications. So the data for this paper were applications that went to NIH. And Rachel Tabak, who is a terrific researcher, led this team, and this paper remains a helpful tool in pointing us to frameworks that are more or less applicable to the study at hand. Everybody with me so far? I realize I'm talking kind of fast. I like this stuff. So another critical component of implementation is figuring out the how. We've talked about the need, which is through the quality gap. We've talked about the what, which is the evidence-based interventions. And we've talked about the stakeholders and the plan. But selecting the implementation strategies, that's really where we get to the how to do it. And those, again, I didn't know what strategies we should be teaching in IRI. I didn't know what strategies I should be working with through my consulting and our CTSA and our implementation research core. So we reviewed the literature to see what kinds of strategies were out there in the literature. What were the active ingredients for moving evidence-supported treatments and quality improvements into usual care? So we were saying, how do you do this? And I think their importance is highlighted in the fact that now the D&I program announcement indeed states that the primary purpose of implementation research is to identify, understand, and develop strategies to achieve these implementation outcomes and getting evidence-based interventions into play. Since the first paper was, this paper was a literature review, we reviewed tons of literature and found 68 different strategies that we could distinguish, and we proposed that they were could be lumped in these 6 different categories: planning, educating, financial strategies, restructuring, managing quality, and policy. But we realized that the field was moving, and we wanted to get some expert consensus on this this topic of what are the strategies. And that led to our refined compilation of implementation strategies that is known as the ERIC project, or the strategies in the ERIC compilation. And we wrote a couple papers about how we did that work, if that might be of interest to some folks. So here we found, I think we ended up with 72 strategies where we'd identified 68 before. And instead of 6 categories, we came up with a few more. And we used concept mapping, which is a method that I love. It combines qualitative and quantitative work. And these shapes in this is called a concept map. And these shapes, the size reflects not only the number of elements, but also the number of endorsements of those elements. And their positioning reflects how close they are to one another. And you can read our paper on the concept mapping process. But for instance, we see on the right-hand side of the screen 3 strategy types or clusters: the support clinicians, the provide interactive assistance, and train and educate stakeholders. Well, you can see that those are all kind of training, so that's why they're close together. But up at the top, the utilize financial strategies and change infrastructure, those are more administrative, and so those you will see are farther away from the position of the developed stakeholder relationships and engage and training and educating. So that's just an interesting feature of concept mapping. Several of us have done research on sort of how are people implementing in the real world. We've used the ERIC's compilation to develop surveys to ask key informants, do you use this implementation strategy, to try to get a sense of the strategies that people are using. And in a couple of my studies, I've found a consistent finding that people who are using more strategies are more successful in adopting change. But, I want to stick with this for a minute. Kind of the daunting thing is the number of strategies that people are reporting they're using. We queried intermediary organizations or purveyor organizations, which we got from the SAMHSA evidence-based practice old resource site that identified dissemination shops for many evidence-based interventions. And we queried them in a paper that you can find in Implementation Science. What are they doing? And we found that they were using about 20 different strategies. This number of 33 comes from a VA study that Sherry Rogel led, an IRI fellow. And she found that the clinics who used, who were more successful in launching new treatment starts for hepatitis C were using 33 steps, a mean of 33 strategies, where the clinics who were less successful at launching new hep C treatment were using half that number of strategies. Well, as a strategy researcher, that worries me, because that's a lot. And Joanne Kirchner and I have friendly discussions about, Joanne says, yeah, implementation is that hard. It takes 30 different strategies. And I say, is that too much of a burden? Is that an administrative burden? Don't we need research to figure out how we can do that in a leaner way with fewer strategies, more efficiently or more parsimoniously? So, I think this is a challenge for the field. How many strategies does it take? Anybody remember the old limbo game? How low can you go to get under the bar? So how low can we go to effectively implement in terms of potent strategies or packages of strategies? So that's kind of my take on these findings that, it takes a lot of strategies to produce change. And then finally, the critical element is evaluating implementation success. And in the slide that I started with, I illustrated that in addition to clinical outcomes, we need to be measuring implementation outcomes. This is important because if we skip this step and only require on clinical change, we might have an effective intervention and we don't see clinical change. So do we conclude that that intervention was not effective? No, we should not. We should first check to see if it was even adopted, and if it was adopted at such scale that most people got it. Was it implemented well, or was it implemented with poor fidelity, in which case we should not expect to see change in clinical outcomes? Or did people begin delivering it, but reverted back, kind of a regression to the mean of what they were doing previously, so they didn't sustain it? So all of these risks would mean that, you know, we would conclude that the intervention wasn't effective when in fact we didn't check to confirm that it was implemented well. So since we published the 2011 paper, there's been a lot of advancement in the field around implementation outcomes. We know that fidelity is the outcome that seems to be most frequently measured. Although I'm currently engaged with a team, we're reviewing 10 years of research since our publication of the 2011 article, and we're going to re-examine some of these trends. We know that we're assessing a lot of implementation outcomes through surveys, through provider attitudes. I'm intrigued with and have seen very little research, so here's a challenge to you researchers. I'm convinced that implementation outcomes interact with one another. I have seen in my own work skepticism, particularly I was trying to co-locate collaborative care for depression in the Missouri Division of Aging system. And even though our service system research had documented that over a third of older adults were entering this system of care with active depression, even the frontline providers and the administrators said, yeah, they're depressed, they're old, they have functional impairment, they're sick, and they're impoverished, and they have social isolation. Of course they're depressed. So there was huge skepticism about whether any intervention, any psychosocial intervention would be effective for depression in this population with so many serious co-occurring conditions. But when we got our foot in the door and did the trial and people's depression improved, we saw great excitement in this system about bringing this intervention in, because seeing its effectiveness led them to be more accepting of our initiative. We also have reason to suspect that high cost interventions or interventions that are costly to implement are going to be received as not very feasible. We just don't have the resources for it. So I'm really interested in seeing more tests of these relationships between implementation outcomes so that we might eventually map where should we start. Should we start working on acceptability? Should we try to persuade people of feasibility, or should we, you know, which of these implementation outcomes might lead to another? And then finally, we know that a high priority area of research is sustainability and scale up and spread, because there's been less focused on that. So I'm going to close with some priority topics for advancing the field, a little bit about research design, and some resources. So I think, you know, some of the priorities in our field are accelerating translation of research to practice. How do we speed it up? Boy, is speed ever the hot topic with respect to COVID. Warp speed, you know, in implementation science, we bemoan the old 17-year statistic that it takes 17 years to move something into practice. Well, can we speed it up? Should we speed it up? Certainly the complexity of the variables that we address in implementation science poses complexity for our research methods. Systems are dynamic. There is constant churn. How do we measure systems that are changing? How do we increase the rigor of measurement in these very challenging constructs? And what measures are really feasible in real world settings? You know, it's rare the federally qualified health center that can record their providers and review their interactions with clients to code fidelity. So how do we get more nimble, usable, pragmatic measures? Mechanisms of change, what changes what? And then, of course, in addition to dissemination research policy, D&I is an important issue. So how do we move forward? Well, I showed earlier that National Resource Council slide that showed a sequence of sequential phases of types of studies. And in D&I science, we're trying to speed that up by introducing hybrid designs where, in fact, I'm hearing that, you know, every intervention trial going forward should try to capture some information about implementation, because that's going to move us just that much farther ahead. Other design innovations are designing for dissemination and implementation at the outset, and figuring out how we can tap easily accessible data. So the Jeff Curran article is the classic for introducing you to hybrid designs. I'm sure most of you are familiar with it. Some of the questions yesterday in some of the consulting that I did with your members of your team were, what are the paths to dissemination and implementation? How do you get started? How do you, if you want, how do you make your research more squarely D&I? Well, there are many, many paths. Some of you have expertise and methodological skills in studying the interventions, the kind of what to implement. And you may move toward implementation research from that perspective. Others of you, like myself, may come from health services research, and you know systems of care, and you know practice variation in that. And again, that's an excellent starting point. Some of you are population specialists. You may be focusing on older adults or children with mental illness, and you know their needs. You can certainly move toward D&I from that perspective. And some of you are setting or sector specialists, criminal justice, school. So all of these, I think, are equally good and equally valid paths toward D&I research. Our field has a number of books. I love to teach out of the Grohl book on the left, Improving Patient Care. Certainly on the right, Sharon Strauss's book on knowledge translation in healthcare is a terrific book. The middle book is the second edition of our team's edited volume on dissemination and implementation research in health. And it is organized to provide chapters around many of the key constructs, like I've talked about today, methodology issues, and also there are separate chapters on a number of settings, social services, schools, public health. I would highlight these, as well as the journal Implementation Science, and now the new journal Implementation Science Communications, both published by BMC. My favorite feature of implementation science that I use multiple times a week is this homepage where you search articles within this journal. You can insert anything in there and click articles and get a good literature review. One of the more recent searches I did was study protocol items articles, and you can see that I came up with 748. you could type in emergency medicine and see what has implementation science published in that setting. You could insert the name of a strategy, such as checklists. So it is, it is like literature review at your fingertips. I love that. I love that feature. I want to highlight a training opportunity that I hope will be well underway a year from now. We just submitted in May a competing continuation for our Implementation Research Institute. It has been picked up by many different institutes and centers who have adopted our curriculum or our mentorship model. Many of our alums are now trainers in these other training programs. We have shared core faculty across these, and we're trying to move towards some harmonization of evaluation metrics so that we can learn more about how to successfully train in implementation research. Just up the road from you are a couple of IRI alums who are at Brown University. And, I know that it's a short commute, relatively speaking, in New England. And so don't let geography, or in this case, Zoom, means you can get together in any capacity. I'm a big fan of networks of implementation researchers and trying to link with other implementation researchers, especially those who are in a subfield. And so I encourage you to network. I really have to make a plug for the 13th annual conference on the science of D&I in health. It is based in Academy Health, and the program just gets stronger every year. It is virtual this year, of course. So check out, if you just search 13th Annual Conference on the Science of D&I in Health, it'll take you to the place where you can register. I need to do that. I will be there, and I will look forward to seeing many of you there. So thank you so much. Oh, I meant to add my Twitter handle here, but I'll send it to somebody. So if you're on Twitter, look for me, and I will follow you because I learn a lot through that media. So I'm open for questions. I think that's our next on our program.
Yes, thank you, Anola. That was just a really lovely overview, and thank you for providing us with so many resources. We do hope to make your slides available to folks, so if you could send your slides to me at some point, because I was trying to snap pictures and gather up all the goodies you gave us. We do have quite a few questions coming in, and if you all have more questions, just send me a note. It's Catherine Sabella through the chat. And I'm going to play my Oprah microphone sharing right now. So the first question comes from our colleague, Michelle Mullen. Michelle, do you want to ask Anola your question directly?
I sure do. Thanks. Hi, Dr. Proctor. Thank you for your presentation. Wonderful. So I had a question related to some of your work and your thoughts. So in most of your publications, you use the word innovation that encompasses evidence-based practice. And so for many of us who are intervention researchers, we are innovating on what would be considered a base evidence-based practice. But many of our funders are not actually interested in innovation. They want evidence-based practices. Right. So could you talk a little bit about the friction or trap of EBPs versus innovation, particularly around the federal legislation that occurred back in Obama, how EVPs were the thing that we wanted and how that may be rate limiting. So if you could share some of your thoughts, that'd be super helpful.
Yeah. That's a great question. And I hadn't really thought of the implication that my choice of words might carry, that because I think of an innovation, I think of an evidence-based practice as an innovation in an implementation lens.
Absolutely. I figured that's what you meant. Yeah.
Yeah. I think of it as, and I come at that from the perspective of the implementation site, because we are, by definition, working with people to do something new. And I have learned a lot from the innovation world. I'm wrapping up a project over the past couple of years of actually working with entrepreneurs to figure out what's the difference in the way entrepreneurs approach innovation from, how do they differ from implementation researchers? So, one of the things I typically ask groups that I'm starting to partner with or hear about their challenges if they come to me is saying, what do you want to be doing that you aren't doing now? And when's the last time you introduced something new? Please tell me about that and how it went. Because I think implementation researchers should never fool themselves that it's a blank slate out there. People are delivering services today. And if they're going to adopt something new, that's a big change for them. And they may wonder, why they need to do this. So in a sense, it is innovation. And I think as individuals, we differ in our readiness to adopt something new, be it technology, be it wearing masks. We as individuals, we have responses to new, and systems do as well. And when I'm often surprised when I say, tell me about the last time you adopted something new, and I'm thinking of an evidence-based practice. In a recent conversation, they said, well, we changed our supervision scheduling and arrangements. And that isn't at all what I expected, but I went with it and asked them to tell me the story of that. And I learned about some real roadblocks that they erected for themselves, and the work that, and the resentment that developed in the way that played out. So, so that's my excuse for using the word innovation, because I'm thinking that it means something new. It is really interesting to think about the tension between, really what you're raising is how solidly established does an intervention need to be before it warrants implementation? Or I hear that as part of your question.
It is. It also suggests, part of my question comes from, if an evidence-based practice actually could use improvements, right? So it's not wildly amazing. It doesn't get the outcomes that you'd be like, oh, you don't have to improve this anymore. But the call for the evidence-based practice limits the innovation, because then once you innovate or adapt something enough, it no longer is an EBP. And I understand, the IMPSI world, that adaptation is seen as a little bit differently than perhaps in other places. So it was really about that friction of how much innovation do you have when we're calling for EBPs only, as compared to adaptations or modifications of EBPs and then become something different,
right?
Especially if they need improvement. Yeah.
And I think, that kind of depends on whose voices are issuing those calls. So I'll be interested in seeing where you go with that. That's an important challenge. And, as I said, and you can glean from my earlier remarks, I think all interventions I think adaptation happens in the real world, whether we admit it or not, whether we want to or admit that or not. And I think adaptation is a good thing. I think it can't be haphazard and random. And if we can find that magic tension between keeping the key elements to ensure the effectiveness, perhaps that's why there's such a strong voice calling for us to continue to monitor client outcomes, at least on a subset when we're in hybrid 3 type trials, and focus mostly on implementation.
Thank you.
Thank you. I appreciate that.
Thanks, Michelle, for the question, and Anola for the great answer. I got a couple of questions. I'm going to actually try to blend them together because topically they're similar. I think the you had a couple slides about the different implementation strategies. And so a couple of questions were just kind of twofold. One, what should your strategy be for choosing which strategies to go with? i.e., are there some strategies that are more effective than others? Or is it more of a quantity over quality kind of distinction? And how does that interplay with cost burden, right? And so if you're just like throwing a bunch of strategies at the wall, that's usually also more expensive. So can you just talk about that tension, if you will, and how to go about deciding which strategies to use?
Yeah. And, and I need to fess up that I am not a particular strategy proponent or adherent. But we do have experts who are spending their careers honing, fine-tuning particular implementation strategies. I think of my very good friends who are advancing the literature around facilitation as a strategy. And of course, even mentioning facilitation as a strategy reminds us that strategies vary in their complexity. Some strategies are, in fact, composites of multiple discrete strategies. And in our first paper on the compilation of implementation strategies, we distinguish between discrete and bundled or complex strategies. So an example of a discrete strategy might be a checklist, although we know implementing checklists can be kind of complicated. Or, I've even heard people say that a memo instructing people to do something or a policy is a one-shot strategy. So first of all, strategies vary in their complexity. I believe that, in the next decade, we're going to have a very solid body of evidence showing us the effectiveness of certain strategies and hopefully the relative effectiveness of strategies in relation to each other. I hope, we're seeing not only effectiveness research on strategies, but comparative effectiveness research. And then as our work in the team led by Sherry Rogel illustrates, packaging or clusters of strategies. And so computational configuration methods are going to be important, where we see what strategies need to be employed with what other strategies. There are inclusions of strategies in the EPIC collection, in the Cochrane collection. That was 2 collections, but effective methods of practice change. For instance, you can search the Cochrane collaboration and get the evidence on use of champions or consensus panels or collaboration networks. So as we accrue these bodies of evidence about where and when and how well different strategies work, I hope we will be approaching strategy selection from a position of knowing effectiveness and knowing nuanced information about where and when they are effective. I expect we're going to find that strategies for maintenance and sustainment and scale up are going to be very different than strategies for initial adoption. In terms of, is it the quantity or the particular strategy? I don't know yet. There may be an article out there that sheds light on that, but I see all of these questions as being high priority, recognized as high priority of the field, and kind of where the action's going to be. So I guess my answer is I tend to approach things from a review of the literature on evidence first. I also place high premium on what that setting's prior experience in implementing has been. I'm part of a research team where we study the implementation of hypertension care in Rwanda. And I was struck in my first trip that we spent 10 days with stakeholders and studying the system of care. I kept hearing how effective their health ministry had been at HIV screening for prevention and control. And yet there was very little work in hypertension. So in a return visit, I spent most of my time not showing them the evidence about implementation strategies, but listening to them about how did you go about bringing HIV interventions into effective use or fidelity, widespread use. And then I worked with them to think through, which of those strategies might be transferable to a new challenge of hypertension control. So, and I have that preference to ground my work in knowing what the setting and the stakeholders have used previously, not because I want them to get set in using a hammer all the time for every nail, screw, tack, etc. But it tells me a little bit about their skill set and their confidence. And so it's like evidence-based practices. What are the preferences and what are the evidence? So those two are my primary criteria in thinking of strategies to suggest or to test in a particular setting.
I appreciate that. That's a really good point. I know Gina has a follow-up question along those lines. Gina?
Yeah. Thank you, Dr. Proctor. This has been a wonderful presentation and very great information. I had a follow-up question about that because I was one of the people that asked about the strategies. Maybe strategies isn't the right thing to ask about because that's getting pretty fine-tuned now that I hear some more of your examples. But steps. So there's implementation steps. You talked about some of them. I know the different frameworks have different steps and they have them in different order, but things like stakeholder buy-in, strong leadership supporting the innovation, training and staff competence. Are there any steps that has there been research around any of these steps being more critical than others or that are the secret ingredient? Or is the rule just do it all, you need it all?
Well, there are some frameworks, and I don't want to neglect some by mentioning others, but certainly the EPIS framework that Greg Ahrens has developed is getting a lot of research attention, and it does distinguish between, if not steps, phases. And I think sometimes it's 2 steps forward, 1 step back, especially if we have a learning organization perspective. If we get down the road and we see things aren't working, maybe we need to go back and do some other things. So I think phases that we can expect to sometimes be sequential and tidily sequenced, but other times dynamic and interactive and recursive. So I would point you to the EPIS framework for starters around that. And they're beginning to look at what strategies work in what phase as well.
Great. Thank you.
Thank you for that. Beth Lucas, I see you. So I just thumbs up or thumbs down or unmute if you have a follow-up question, because you also had asked about strategies. Thumbs up. Great. We're in good shape. Okay. Anybody else have questions? I can ask one that was brought up that might be applicable to some folks here. Dr. Proctor, as you may have learned from this morning, we have, at least within iSPARC and PQHS, a focus on, community-based participatory research and a long history of doing so with multiple populations. And you kind of highlighted on, you have presented a couple of slides where it's clear that CBPR kind of enhances products, enhances processes, and also dovetail really nicely with what seems to be a current focus on user-centered design. And even I loved when you just said too, this idea of sometimes the best strategies aren't necessarily what the evidence says or what some article says, but more about what the stakeholders that you are doing the implementation with you. So that was a lovely example, but I just thought maybe you could talk for a few more minutes about how you see or have done CBPR or kind of stakeholder input in your implementation activities.
Yeah, yeah. You know, and this seems like low-hanging fruit, or it seems like a no-brainer to me that, you know, you can't do implementation research that stakeholders aren't driving, essentially. I view us as, you know, their instruments in trying to, you know, we have to be good guests. You don't go in and rearrange somebody's house. And yet there's, you know, I'd like to see more literature on this. You know, just as the big tent slide that I shared from David Chambers, you know, I'd love to see somebody write a nuanced piece with detail about CBPR principles and implementation research partnerships. You know, I know David and some other NIH colleagues have written about, you know, the necessity of partnerships. The VA is doing a good job with this. I have been on a Query Center external advisory committee, and we have veterans and service recipients and family members on that so that we listen to them. But I think the literature could really use contributions, and that might be something great for your center to work with. And, you know, really get down to the nitty gritty. I worked with someone whose work I just adored, and then she kind of shifted gears. It's Martha Shumway, and she was at UCSF, University of California, San Francisco. And you know, the whole idea of stakeholders preceded my work in implementation science. And I met Martha at the Society for Medical Decision Making conference, which I haven't attended that very often, but, you know, really medical decision making is often what we're talking about in implementation science. And just take the word medical out, and, you know, people are making decisions about what we're going to deliver, how we're going to deliver it, what data we're going to collect. And Shumway had some papers published on stakeholder priority and preference assessment with some really fascinating methodologies that I used in some of my studies. For instance, and I'll just give a quick example because I know we're near the end of time, to highlight that I think we need this detailed exposition of what these allied fields, methodology and conceptually, offer to implementation science. So the quick example is our center engaged Martha as a consultant, and we were doing this project of trying to introduce depression care to the Missouri Division of Aging, which is Medicaid, functionally impaired older adults. And, you know, we had done a depression screener, and we knew who had screened positive for depression. So she led us to a project, and it's published somewhere, where we had those symptoms like crying, difficulty getting out of bed, little appetite, feeling blue. We had those on cards, separate cards, and we put them all out, like, you know, 9 classic symptoms of depression. And we asked, you know, an individual, you know, I'm wondering if any of these words describe how you feel. And they looked at them and would say yes, and we said, would you please pick up the one that you're feeling most strongly? And, you know, and then if you're not feeling that, don't pick it up. Well, many of these older adults picked up every single card. And then we would say, has anyone ever talked to you? Has anyone ever used the word depression for how you might be feeling? And no. And they would say, I'm not depressed. And if we would say, you know, we used the cards to say, which problem do you want to work on first? And so we found these dramatic differences between the providers and the clients on the way they saw their problems. And I think, you know, we could do the same with choices around strategy. What do stakeholders prefer? What do they have confidence in that would work? So, you know, there's wonderful methodology. Sometimes I worry that CBPR, and, you know, you can say, and I'm that's not my field of expertise, but CBPR is often at kind of the global or the concept level. like it's a philosophy. And there are terrific methods. And I think implementation science just need to know and be skilled in using those methods. So I guess I'm ending on a cheerleading note to tell you guys to make that contribution to the literature, or share it with me if you know it's already out there.
Sorry, I'm getting a little distracted here, but I know, Michelle, you had one more question. I don't know if it's a quick question. Otherwise, we can end. We can't hear you. We can't hear you.
I said it may be a quick question. I presume, though, however, it's a longer question. So, Dr. Proctor, if this is not a good question for your last 5 minutes, but in looking at implementation science and its contributions to translate, research to practice, I was wondering if you had thoughts about implementation science being used as a base for workforce development. So there's not a lot of articulated strategies for how do you create a workforce that is skilled in decision making, that can integrate evidence-based practices or innovations that seem to be helpful in certain locations and with certain populations. So I was wondering if you had some thoughts about the translation from IMPSI to workforce development.
Yeah, great question. And I've had 2 situations where I gave myself what I described as qualifying exams for my career as an implementation scientist. And that is, number 1, did I have the guts and could I carry off teaching a class in implementation practice? And so I took that challenge on and taught a class in our Master of Social Work and Master of Public Health students, where the audience were, the students enrolled were not researchers. I worked myself into a frenzy trying to be sure each week that I walked into I didn't want to teach anything that wasn't evidence-based. And that's why I said it was like my final exam as an implementation researcher. What did I have the guts to stand up and say, the research shows us that you should do X, Y, and Z. It was a lot of fun, and I did find some evidence-based content to teach. And then I developed a workshop for clinical supervisors in substance abuse in the St. Louis area. And that article is published in Implementation Science under the title called the Triple Training. And it kind of describes the curriculum that we adopted and the training methods that we used. And we actually evaluated it with a number of standardized instruments. So I would point you to that article. But yes, I think that's really important. And we talk about a research practice gap. I don't want to see implementation researchers contributing to one by developing research on implementation that is never implemented to guide actual implementation by, a key actor are those that do the implementing, and they're often not in our circles to shape our work.
It's super helpful. Thank you. I really appreciated this talk. Thank you.
That was a great note to end it on. And thank you so much. Thank you, everybody, for coming. We will be, like I said, collecting the slides and hoping to post the recording on our website as well. So if you have colleagues that missed it, we'll keep you posted. Dr. Proctor, thank you so much for your time. You have a well-deserved break before our afternoon of meetings begins in about 25 minutes. So thank you, everyone. Thanks for coming.
Okay, thank you.
Have a good day.
Thanks for the great questions. Bye.